and I'm the medical director for MCPAP, and we're pleased to welcome you to the MCPAP Clinical Conversation session, which, as you know, takes place on the fourth Tuesday of each month from 12:15 to 1:15. Today's topic is OCD, Assessment and Treatment Guidelines for Primary Care. A couple of housekeeping things before we start. The session will be recorded and available on the MCPAP website at www.mcpap.org. A copy of the PowerPoint slides will be available on the MCPAP website on the Archive News and Webinars page under the About MCPAP tab. Our presenter will stop for questions at several points during the presentation, and there also will be time at the end. If you have a question or comment, please type into the question box during the presentation. We will read out your question or unmute your line to enable you to ask your question. You will receive a very brief survey following the presentation. We appreciate your feedback to help us improve future presentations. So today's speaker is Dr. Charlie Moore, who is the medical director, or actually the co-medical director of our Southeast-MCPAP team. Charlie received his medical degree from the University of Kansas Medical School, and he is a triple boarder in that he completed a combined residency and fellowship in pediatrics, adult psychiatry, and child and adolescent psychiatry at Tufts Medical Center. He worked as the medical director of the BEST program and assisted in establishing the Tufts Floating Med-Psych Inpatient Unit, which was in operation from 2000 to 2009. He began working with MCPAP in 2005 as the medical director for the MCPAP Boston Tufts Children's Team, and while at Tufts, extended medical education commitment as Associate Child Psychiatry Training Director. In 2009, he became the medical director of the MCPAP Southeast Region MCPAP team and is also the medical director of the Southeast Adolescent Services for McLean Hospital. So thank you so much, Dr. Moore, and why don't we go right ahead and begin?
Well, welcome, and thanks for everyone who's attending following the Memorial Day weekend. We're going to talk a little bit about OCD and the assessment and guidelines for primary care. I'm starting to have a little bit more understanding of OCD over the last year as I've been working with the OCDI residential program here at McLean. So we've have an inpatient or a residential program for teens and youth who have very severe OCD. So we can certainly talk a little bit about that around the extreme ends, but we're going to mostly concentrate on more typical presentations of OCD that you might see in your office. The main goal of the talk today is to have some sense of recognition and how to assess for OCD. It's a fairly rare condition that presents, and there are certainly obsessions and compulsions that are normal for children and adolescents, and trying to tease those out can be difficult. We'll talk a little bit about, at the end, about considering PANDAS and PANS, which are have some relation to OCD in their presentation, although they are much more severe, and it really is not the goal of this talk, but we will touch on it some. We will talk a little bit about the CyBOC, the Child Yale Brown Obsessive-Compulsive Screening Tool, which may be of use in practice, especially if you're going to participate in some of the treatment. And then we'll talk a little bit about effective parental guidance as parents, their stance and the way they manage their child with OCD makes a pretty big difference in outcome. A bit about therapy referral and medication selection. So let's see. So just a little bit of background about OCD. Obsessive-compulsive disorder is a condition in which persons are caught in a cycle of obsessions that cause anxiety and compulsions that he or she uses to try to get rid of for the anxiety. Obsessions are unwanted thoughts, ideas, images, or urges that are unpleasant for the child and cause a lot of worry, anxiety, and doubt. Compulsions are the rituals and behaviors a child feels they must do in order to relieve themselves of the upset feelings. They may believe that engaging in these compulsions somehow will prevent bad things or a negative outcome. So just to kind of give a sense of obsessions, many are a big chunk, especially in the earlier childhood group, has to do with germs, getting sick, dying, and general wellness obsessions. These are fairly common and very frequently something that I think might present in the primary care setting. There's also extreme fears that something bad is going to happen. There's frequently a child might be worried that something bad is going to happen to their parent or to the world, that bad guys might get them. There might be some invaders. They also may have feelings that things just need to be just right. They will frequently talk about this as a feeling first and then an obsession second. Another obsession is disturbing or unwanted thoughts of hurting others or images that are sexual in nature. Compulsions, in general, checking, excessive checking, rechecking, if the door is locked or having their parent check repeatedly in on them. Excessive hand washing is very common. Repeated actions that are trying to get things just right. This is repetitive tapping, repetitive stepping or moving in a certain way. Ordering and arranging things. This has to do with symmetry compulsions. Many will have mental compulsions with excessive praying or mental reviewing. These are more difficult to get at because they are generally internal. Frequent confessing and apologizing is very distressing to the patient when a parent refuses or doesn't make themselves available for the confessing or apologizing. In this day and age, an example will be frequent checking in with texting. That's a newer one that's coming up with repeated texting that kind of never ceases, where the parent is being constantly bombarded by texts, and then the child will become upset if the texts aren't responded to promptly. Saying lucky words or numbers. It's frequently have magical thinking usually related to that. And we kind of touched on excessive reassurance seeking, and this sometimes also involves the primary care physician or doctors wanting to be sure that they are not sick. Also, school nurses frequently see this behavior. So just to get a little sense about kids with OCD, we're going to try to switch over to a brief trailer video of a movie called Unstuck, which is a show that kind of, that's a documentary. Let's see if we can get it going. Almost working there.
Charlie, do you hear the volume?
I do not.
Okay, hold on.
Charlie, we're not hearing anything.
Yeah, getting there.
Okay.
When I would go to bed, I would have to fix my curtains, not just once or twice, but like 10 times, a lot of times, more than that. So it would take me about an hour to go to bed.
The rituals that I had, they all had like different meanings behind them, but one of the things that I had to do is like I only wear certain clothes, and if I wore another shirt or another pants, I would it would just say something bad would happen to like my family or friends.
I had a lot of contamination fears. I didn't like to touch door handles, shake hands with other people, just in fear that I would get sick or catch a disease, that there would just be germs all over me, and I could transfer it to my family and friends. Sometimes if I saw something that I'd never seen before, I would still find out what's not right about it, and then I'd just find a way to annoy myself. I'd find a way to hurt myself and be like, oh, that's not perfect. Don't look there. It's gonna mess you up, and it'll something bad will happen to it, or something bad will happen to me if I keep looking at it, or something. And then I was like, it came to the point where I kept looking at something bad. I was hitting myself and trying to just not look at it, run away or something. It wasn't very good.
I knew all this stuff was fake, but it was hard for me to say no and stuff. So I knew that it wasn't going to happen, but I know that it's unbelievable that I'm just going to poof and I'm a bodybuilder, but it's just so real to me in a way.
Okay, that was so. Just to talk a little bit about the video Unstuck. It's this was a helpful documentary for parents and kids who are going through OCD. It tends to be fairly inspiring and helps motivate them to really do the very difficult work of resisting and combating the OCD. So I just wanted to do that as a little sample to kind of give you a sense of the different types and presentations and generally the main age range that we might see at this for kids. Just to shift gears a little bit to epidemiology. OCD is fairly rare. Its rate is about 1 to 2% of and so that's a fairly rare mental health disorder for us. Having said that, it matched very nicely to our own data. As far as McPAP calls go, about 2% are OCD, so that kind of correlated nicely. In general, that kind of translates to 4 or 5 kids in an average elementary school or around 20 kids in a bigger high school. The mean onset is 19 and a half, and that has to do a little bit with there's kind of an early onset OCD and a later onset OCD. For our purposes, we're really only worried about the earlier onset. So 25% start before 14. Boys tend to be more affected than girls, especially at younger ages, and about 25% will start having their OCD symptoms before 10. Females are slightly less affected in childhood, and more young adult tends to be the presentation, or late adolescence. The OCD course in general it can be frequently a very chronic course with waxing and waning. The onset of OCD, as we said, frequently is in adolescence. About 75% of the time it can start in OCD. The folks with long-term OCD will have had it start earlier in their adolescence, and it is kind of a lifetime thing for them to manage. 40% do have remission, so it's not without its remission, but for many it is something that they, even when it is in remission, that they are constantly vigilant about, managing, and aware. So it's more of a vulnerability that they need to manage for their lifetime. OCD, we'll switch over a little bit to OCD and its impact on families. The OCD tends to really affect the whole family unit. It's very difficult for families with children who have OCD. The intensity of their distress and their persistence and insistence on doing compulsions or reassurance seeking or their obsessions really affects the whole family and can affect many aspects of day-to-day routines, morning routines, evening routines, function of the family, whether they're allowed to go out or not out, and families respond to that in many different ways. Some will become very isolative and feel that they're doing something wrong, that they have some sort of odd family situation. More difficult frequently is how OCD will get wrapped up into the family's or the child's obsessions and compulsions. They'll wrap their families into those, and so that the family becomes an integral part. So this can be stuff like, for example, for compulsive hand washing, the soap needs that many of these kids will want is gallons, and then pressuring the parent into buying lots and lots of soap, or doing certain, saying certain things, or acting in a certain way, or standing in the bathroom with them. These kinds of rituals the parents become part of the rituals, and detangling that can be very distressing. In addition, there's a genetic link for families with OCD. Many, about 10 to 15%, have a parent with OCD, and if you extend it out, there's frequently some OCD in a family member somewhere, but not always. But when it comes up, it certainly makes the treatment and the understanding, and it frequently can challenge the OCD parent to manage their own child, because it frequently will be triggering their own OCD. So just a quick understanding of the neuroanatomy. This is a part that we find very helpful to having the kids and the adolescents understand, and it helps to motivate them with addressing their OCD, which has a lot to do with resisting. But the basic neuroanatomy has to do with the frontal striatal thalamic loop. The basic idea, you can see the frontal lobe, an obsession or a thought will come up. It will move to the striatum, which is probably, to be oversimplified, is the gatekeeper and decides what's important and what's not important, and then moves that on to the thalamus if it finds it important. Thalamus is it provides valence and energy to the unwanted thought or worry, and gives it a lot of importance and makes it feel extremely important and now, and puts a lot of emotion behind that, which then feeds back to the frontal lobe. Children and adults with OCD have smaller striatums than normal controls, and some of the theory, especially around exposure therapy, is really to interrupt that feedback loop, try to build the striatum up, and that's one of the exciting parts of neuroanatomy studies has been that with therapy and or medications, the striatum does change physically in the brain and becomes larger. So the frequent metaphor for many of the kids was we're talking about this is like physical therapy. We're going to do your exercises. The exercise is important and needs to be done daily and regularly to sort of build up that filtering system and to build up that interruption of the loop. In addition, there are many serotonin receptors, glutamate receptors that have that sort of regulate that whole system, and also that's where the serotonin system is felt to be in play for treatment of OCD. So just to shift over, comorbidity tends to be the rule for OCD. They frequently have other mental health challenges. Anxiety disorders are by far the most common. 76% have a comorbid anxiety disorder. These can be very frequently younger childhood age, separation anxiety concerns, simple phobias, generalized anxiety, social anxiety are very frequent. Usually not to the degree of the OCD, but they do intertwine. Major depression, we've seen about 30 to 40%. This is a little bit, some of the kids have major depression, and anxiety and OCD are all part of the same mix. Others get demoralized through their OCD, and depression becomes a comorbid factor for their OCD. ADHD and its related oppositional defiant disorder, a little lower down, are somewhere around a third of the patients have some OCD concern. This gets difficult to tease out because it has to do a little bit with concentration, sustained focus, impulsivity, and these things kind of lap over a bit with OCD. What's an obsessional thought versus what's being able to concentrate on schoolwork or the teacher's task. So it becomes a little bit difficult to tease out, but somewhere in there's some overlap of impulsivity and externalizing disorders. The middle ones, which are on this slide, body dysmorphic disorder, trichotillomania, excoriation disorder, these are all now in the DSM-5 altogether as OCD and related disorders, and so there's a considerable crossover around those disorders, and some of the treatments can be very similar. Tic and Tourette's disorder also are considered kind of a subtype for OCD. When they come up, the patients with tic and OCD are slightly different, and we sometimes do slightly modified medication treatment plans for them, but it's something to keep an eye on. So the assessment of OCD. So usually a patient will come in and the parent may be concerned around excessive hand washing, a repetitive behavior, but this is not always the case. Sometimes it's subtler, and sometimes the parent won't be so sure what's going on, but will know something's going on. About 40% of the children will deny compulsions or drive, or that that's driven by obsessional thought, even when it's very obvious to others. So usually we take family, teacher, and other reports fairly, give them high weight, as children aren't always aware. They become more aware with psychoeducation and being able to label and talk about it, but until they have that kind of language, they just know what they know. They do what they do, so it's not so easy for them to tell, especially the younger kids. Many times, though, the obsessional disorders are slow in arriving or becoming a problem. So very frequently they're secretive or something that's kept pretty private and is not and that parents aren't really aware of. And that's not atypical. And usually I reassure parents when they feel bad about not having noticed earlier that that's not uncommon. So shifting over to the SIBOC, this is a giant slide with there's way too much going on there, but it's sort of to give you the idea of how this instrument works. It's a symptom checklist and then a severity scale. The symptom checklist is a big long list of clusters of obsessions and compulsions. And these include, in this slide, aggression, contamination, religious, hoarding, somatic concerns, hand washing, checking compulsions, and then there's kind of a check of current or past, and it's really a giant inventory of symptoms. And it's sometimes helpful to kind of go through a list like this because it's not always understood as a compulsion or obsession. This frequently comes up, for example, with hand washing and germs. Some children will think they're supposed to be as worried as they are, and this kind of helps highlight those that maybe this is too much. So moving on to the severity scale. The severity scale is divided into obsession rating scales and compulsion rating scale. The obsessional rating scales has to do with time spent on obsessions, interference from obsessions, how much distress the obsession causes. And these last two are kind of important, how much resistance the patient's able to give towards the obsession and how much control do they feel over that obsession. And then the compulsion rating scale, again, is similarly put. So these scores, this kind of gets added up into some scores from subclinical to mild. Generally, for those obsession and compulsion rating scales that are less than 15 to this scale, so that can be some distress, some compulsion behavior, a few hours a day. Those will fall in the mild range. Those tend to be recommended to manage by initially first doing psychoeducation, trying to help the family and child understand that there's this thing called OCD and that they're going to try to resist, manage, and try to take care of that. That frequently will be enough with everybody understanding what it is and then starting to work and practice towards not giving in or resisting the obsessions. And over time, many children will be able to back off from that. That frequently has to do with hand washing, contamination issues that kind of get a little excessive, and with some guidance can kind of come back and to be within more normal realm. More severe, moderate to severe are much more difficult and usually will need a professional's help. So we'll talk a little bit about the POTS study. This was done in 2004. It was a comparative OCD study for comparing CBT plus an SSRI, which for the POTS study was sertraline and sertraline alone, and then a placebo medication alone. So the big results were that the most effective treatment really was CBT alone or CBT with medications. CBT combination with medications outperformed CBT alone, but medication was not recommended to be sufficient alone without therapy. So that study lends us towards really the thought process that medications are a support to therapy, but really aren't necessarily a great option as a treatment without therapy. So when we say CBT, what do we mean? This is cognitive behavioral therapy. So this is a treatment. CBT in general is having people aware of their thoughts and how those thoughts affect behaviors, and working towards that. Exposure therapy is a extension from CBT, where children learn to face their fears and exposures without giving in to compulsions. And what this typically looks like is we tend to have them develop a hierarchy of fears or compulsions or obsessions, from what's most difficult to what's easier. So some obsessions they have a little bit of control over, and some they may feel very much are way too scary to manage. Let's say a fear of causing harm to a parent. That usually is a very distressing and severe one, versus an obsession about symmetry or tapping or things being just right is less distressing. And they begin practicing exposure to lesser, easier ones, and then kind of move up their hierarchy. So these are usually a designed exposure and practice with having the child in distress for a certain amount of time without becoming overwhelmed, and then repeating and practicing that. That frequently needs some guidance with a professional. It's pretty difficult for children and the therapist to do. There's quite a bit of anxiety and distress, and it's quite an uncomfortable therapy. So I really have to say that the kids who are doing this therapy, it really requires a lot of support and encouragement about how brave they really have to be and how brave they are when they're engaged in this therapy. Shifting to OCD medication treatment in general, again, we kind of think of these as medications as a support. The guidelines really are around that serotonin reuptake inhibitors are helpful in reducing OCD symptoms in children, making the exposure therapy easier or more effective. So that's rather than the treatment alone. And that's generally a healthy perspective for the clinician and the family to have, that this is a helper, but that the hard work is really through the therapy. So as far as medications do go, there are 4 FDA-approved SSRIs, sertraline, fluoxetine, and fluvoxamine. Did I say that right? Zoloft, Luvox, and Prozac. There are other SSRI medications that have some academic support, but these are the ones that are the FDA approved. And generally you prescribe these as you would an anxiety medication, using lower doses, going slow and being careful. Many of the children also have comorbid anxiety, and so being very cautious and careful, especially around support around minor side effects, is usually fairly important, and it's usually better to go slower and reach an effective trial than to go too fast, have a adverse side effect happen. And the OCD kids tend to be a little bit more vulnerable to becoming obsessively concerned about the medication, and then it becomes much more difficult to then use medication. You may even have to do exposure therapy to get them to accept pills, for example. So the 3 that we have really listed here, the sertraline, the target doses tend to be 100 to 150 milligrams, max dose of 200 milligrams. It is not uncommon once we get to these higher doses that there is some somnolence, especially with Luvox and Zoloft. They do tend to cause that, so very frequently they are at nighttime or in divided doses. Luvox also it has sometimes I do personally like the added benefit of some somnolence, especially with Luvox, because it does help with some insomnia challenges that may come up for kids with anxiety. So sometimes you kind of get some dual benefit, but also you can get that with sertraline once you hit the higher doses. The same black box warnings are important with these SSRIs as they are for SSRI use in depression and anxiety, meaning you do need to warn the parent and the child a little around intrusive suicidal ideation and have a plan about how they are going to communicate that, and a safety plan and guidance around discontinuing medications and alerting their clinician or going to an emergency room if severe or acute, and certainly consultation to MCPAP is reasonable in that situation too. So shifting a little bit from back to the family, I'm going to say that I really am going to keep emphasizing that parents need to be very involved because of how much the OCD tends to involve the family, and getting both parents on board or all the family members on board around trying to reduce and resist in a kind of a thoughtful way, accommodation and reassurance seeking. This is an area that children are naturally going to want to seek support or reassurance from their parents, and the parents are usually going to want to give it, especially in the face of severe distress. Unfortunately, that's it's not always the right thing to do. So what this means is kind of coaching the parents to say stuff like, you're going to be okay. We've talked about, one reassurance, and then after that, then repeating things like, we've already talked about this. What did I say 5 minutes ago? That referring to their prior conversation rather than repeating the reassurance over and over again. That type of perspective. The parents are, especially in ERPs, are brought in as coaches and kind of like in physical therapy, are given homework assignments of areas to practice, obsessions to practice between visits with their outpatient therapist. So that's sort of the OCD. I'm going to go back to OCD. So that's mostly the OCD background and the treatment of that. I think the pediatrician's role frequently is helping guiding parents towards treatment, finding a proper therapist. We certainly struggle with challenges of finding, qualified exposure or CBT therapist, but most therapists are very willing and will make effort to at least begin making exposure plans or CBT plans, and with support frequently from the Institute of OCD or other local resources, can at least begin some of the therapy in their office. And so that I would say that finding a therapist and then engaging that therapist with finding supports through all the resources that are kind of available within Massachusetts and the larger world is probably a better place to start rather than trying just to look for the exposure or perfect CBT therapist, because getting things started is frequently the important part. And then families also need a lot of support around how to manage and their affect, and so there's a lot of good support in that area. The other part about OCD is that the medications tend to be in a supportive role. The kids in the movie in Unstuck, most of those kids are off medication by the time that they're able to manage on their own. So that is the idealized scenario, is that they're on SSRIs for a few years, do the exposure therapies, and really work to a place where they're able to self-direct and create their own exposure therapies, or own exposures. And the kids who are fairly successful with this will talk about that they have a trigger, that something will come up, it's flu season, and they're starting to feel worries about germs, and they'll purposefully start doing exposures or creating exposures that challenge their OCD to get past that on their own. At that point, usually most of the kids can slowly begin withdrawing off the SSRI successfully when they're able to do their own self-directed exposure therapy. So let's contrast that a little bit with the other thing in the office that is OCD but presents in a very dramatic fashion. These are PANDAS and PANS, which are pediatric autoimmune neuropsychiatric disorders associated with strep and the pediatric acute onset neuropsychiatric syndrome. These present differently than OCD for the most part, in the sense that they're fairly sudden. They are usually very distressing to the family and child. There's an abrupt change in the personality or behavior of the child. And so these are usually not subtle. These are fairly urgent visits that have usually a high worry factor. So let's see. So what is PANDAS or PANS? The hypothesis is it's an autoimmune antibody attack of the basal ganglia by some sort of infectious agent, strep or other. The important part about the PANDAS is that there's usually some looking for active infections. If found, should be treated. There are also, and we're not going to go into it, but other ways to sort of look at the immunosystem of the child and getting some suggestion of whether this is part of the complex or not. But usually, the presentation is fairly quick, meaning within days, and very severe. So this is the last slide. This is the OCD versus PANDAS slide. Pediatric OCD frequently is seen between 8 and 12, although it can kind of be at any time in the adolescent's life. PANDAS tends to be typically of, prepubertal, so before age 14 or similar is part of the definition of the diagnosis. The timeline, again, is the PANDAS and PANS are very dramatic onset, where OCD frequently is slightly more slow, subclinical symptoms, and again, the child usually, or the family usually, will be able to kind of look back and kind of go, oh, that was maybe an obsession, or that wasn't a compulsion, or yeah, he used to have this hand-washing thing, or something similar. The PANDAS tends to also have some comorbid challenges other than just the OCD, which include movement disorders and severe separation anxiety, anorexia, not eating, urinary frequency, incontinence, and other kinds of losses like handwriting or acute academic losses. The treatment of OCD is what we talked about. PANDAS is a little more difficult as the treatment keeps shifting around. Again, testing and treating for active infections is probably important. Again, with any of these, OCD or PANDAS, they are fairly rare, and I would encourage anybody who, a primary care physician, to consult with MCPAP or a specialist if needed, just for it, even with lower level OCD, just for guidance and thinking things through and monitoring, as these are much rarer. And so we'd be happy to help you all out. So I'm going to kind of stop there and leave it to questions and answers section. I see Dr. Bornstein. Am I supposed to do something?
I don't think they've finished their question yet.
Yeah, we don't
okay, sure.
In the box yet.
All right.
Beth, are you going to read the questions?
I can, yes.
Okay, great.
So the question is there a resource online of local specialists for OCP therapy for us to access?
Not really. I mean, I think there's the IOCD, the International OCD Foundation, has a list of resources, and so they do. So you can kind of go on their website, and they have some guidance around that. It's much more difficult other than that, because if you use the regular internet like Google or something like that, therapists will put all kinds of things, like OCD and couples therapy, and there's have a big long list. So I think that's much more difficult. I think it tends to need to be somebody who's comfortable or works with anxiety, or even better if they know CBT. Other than that, certainly talking to MCPAP is a good way to sort of begin that conversation. But it's usually a hunt, trying to find a good OCD person. That's why I generally encourage people to try to find the best therapist they can, and very frequently a psychologist or somebody who states that they have been trained in ERPs. The other part, the struggle with exposure therapy and finding a good therapist is they don't always take insurance. Many of the better exposure therapy therapists go to the home or go to wherever the exposure needs to be, so they're much more community involved, and so that tends to be more difficult for them to figure out payment parameters, so that they don't always directly take an insurance, but certainly families can resubmit their claims.
So it looks like there's another question.
Yep.
Want to go ahead, Beth?
Oh, any recommendations on how to communicate with schools around needed interventions for kids with OCD?
Yeah, so that ends up being very complicated. Probably the thing that we see most frequently is over-accommodation versus working with a plan to manage the OCD in the school or in that setting. And this becomes a very difficult, how difficult is the OCD and the timing of that. Many of the cases that kind of expand and get worse have too much accommodation. So I would say really having a chat with or having the parents start chatting with the therapist and the school guidance becomes pretty important. So things like being able to visit the nurse whenever they need to, or allowed to leave the classroom when distressed, that frequently leads to more accommodation and tends to worsen the OCD versus lessening the OCD. So this is where OCD becomes kind of complicated, because many of the natural things we might do to kind of support and care for or in fact kind of go the wrong way and kind of feed the OCD. So that becomes a challenge. So I think it kind of gets to be a bit specific for the kiddo, but certainly that's an area where MCPAP can sort of chat and talk about and try to untangle what's accommodation and what's support.
Yeah, and kind of a follow-up to that, they've had patients where the compulsions were dealt with in a disciplinary system. So I don't know if you have any words of advice other than talking to the school.
Yeah, yeah, I mean, you're trying to find that balance between not being, not doing the disciplinary approach and understanding how hard it is, and yet trying not to over accommodate. So it is a really, especially for the more moderate to severe kiddos, really kind of a challenge to figure that out, and usually needs a lot of discussion and trial and error, and we think it's this way, and so we're going to be a little more pushy, and then we have to back off. So it becomes a dynamic conversation. This is usually where I think a therapist, even if has some has not had a great hasn't done a lot of exposure therapy, certainly can really help mediate for the family and the school these kind of conversations. Even if imperfect, it starts to approach the right conversation.
Another one came in.
And PANS and PANDAS is very touchy. Families can latch on to the diagnosis by virtue of what they've read online, and they might may be vulnerable or untried treatments. Any thoughts?
Yeah, the thought about PANDAS and treatment, I'm not sure if I emphasized it here, but I would say that the OCD, regardless of how it presents, the OCD usually does linger, even if some of the severe symptoms either on their own natural kind of just dissipate, or some intervention is helpful, like an antibiotic or anti-inflammatory. But usually the OCD, or very frequently, there's some aspect of OCD or anxiety that continues. And so trying to guide the family, again, to this advice that exposure therapy is very important, and getting them into a therapist as the primary treatment helps kind of mitigate some of the, very some people go to very extended efforts to try to manage the kind of autoimmune system type concerns. So usually that's kind of the approach we go with. That yes, they've had PANDAS and PANS. That's the onset and the why, and but they're going to have ongoing OCD, and let's keep managing that, and where's your accommodation, and how are you doing with your exposure therapy hierarchy, and where's the family and the child with that aspect, how much accommodation is being made in the home, how's the kiddo doing with doing their own exposures or bringing them up, or that kind of thing. So trying to shift that conversation, but I do agree there's a challenge in the PANDAS diagnosis that some families will really seek a sort of a magical cure or immune disorder fix, which is very hard with where we are right now with our understanding of PANDAS and PANS.
Then we have another one, which is, other than the CyBox, CYBOCS, are there useful screens for OCD that we could use in general pediatrics?
Yeah, so we've been looking at that. MCPAP has been looking at the different types of screens and screening systems. I think I think our consensus was that if you were going to use one, you probably should use this one really because of its standardization. The challenge of using any screen is really amount of time, and then how to decode it. So that is a challenge and a burden. But there really aren't any good ones that are any simpler, or if they're too simple, and they sometimes create confusion. So I don't know if anybody else wants to respond, but I think we were kind of settled in that this is really the one that's probably the most helpful. There's also other ones like the Maudslay's OCD scale. There are several other ones, and they're usually better in the symptoms, right? So in trying to find all the different aspects of OCD or uncovering OCD, where they really don't help is so much as in the severity and knowing how severe the problem is, and then using some sort of severity measure. So I don't know. It's sort of an area of could be perfected, but I think right now we're thinking this is the best one, the SIBOC.
Yeah, a lot of people. It's Barry Sarvet here. As Dr. Moore said, that we've really considered a number of the scales and really settled on the CY box as the one that's most user-friendly. It's a little bit intimidating, I think, because it's got the 2 stages where you have to identify the core OCD symptoms first, and then you do the rating scale. But once you kind of identify those symptoms, it's a really easy and quick scale, and it's also really sensitive to change, so that if you're using it in the context of measurement-based care, it's probably one of the most practical tools to use. Anything else on the questions? Yeah, it looks like we don't see any other questions. All right. So any final words on your part, Charlie?
Just that to recognize that OCD is a rare disorder. It can be very severe, and it is complicated. It does not always follow, the treatment doesn't always follow other similar pathways as anxiety disorders or depression, and I'd really encourage pediatricians that this is an area that where MCPAP is helpful to follow along and support, and that because of the nature of OCD and the rarity of the OCD, pediatricians are going to be brought in sometimes as part of the team just because there is no team and having to develop that. So I'd really encourage folks who have those kiddos that they're catching with OCD to share them with us, and we can help follow and guide care.
All righty. Well, thank you so much, Dr. Moore, for the excellent presentation, and thanks everyone for attending. And please, if you have a moment to fill out the online survey that'll pop up once you exit the conference, we'd really appreciate it. And we'll see you next month.